Good afternoon, everybody, and welcome along to session 6 of Value in Health Week, where we're about to turn ourselves to the world of finance, or finance, value and costing. My name's Gareth Setter. I'm the Head of Communications and Engagement at the Welsh Value in Health Centre, the national programme for value-based healthcare in Wales. Thank you for joining us. I'm really pleased and extremely grateful to introduce you to our speakers today, who, to be honest with you, have really helped me out. I feel quite guilty because I said to them, I've got a great idea, let's do finance in Value in Health Week, and then left them both to create all the content. So take this as a public apology, both. But I'm delighted to introduce you to, first of all, Mark Bowling, who is the Assistant Director of Finance and specialises in value at Health R. Mark specialises in costing, business intelligence, and of course, value-based healthcare. Good afternoon, Mark. Thanks for joining us.
Good afternoon.
And also delighted to introduce to you Lisa Powell. Lisa's the strategic lead for the Welsh Costing and Benchmarking Programme within the newly named Financial Planning and Delivery, the NHS Executive. Afternoon, Lisa.
Hello.
I'm going to leave Mark and Lisa to it. Just to let you know before I do, a couple of things. All our sessions are recorded, so this session is automatically recorded, and they're all on our YouTube channel, and they'll be on our website as well later today, which is vbhc.nhs.wales. And also, just to say, we've had great engagement from people watching our events by using the question and answer section at the top of your screen. So we know with these live events, it turns your camera off and it turns your mic off. So please, if you've got any questions at all from Mark and Lisa, pop them in the chat there, the Q&A chat as we go along, and we'll put them to them both at the end of the session. So that's enough from me, and I'm going to hand you over to Mark and Lisa. Thank you very much.
Thank you very much there. So welcome to this Value in Health Week. Hopefully you'll enjoy this session and hopefully it will be helpful. So what we're going to cover is why do we need to measure costs? What costs do we measure in healthcare in Wales? How do we measure the costs? And then the different approaches. So you may have heard of PLICS or patient level costing, time-driven activity-based costing, or a hybrid approach, for example. And then once we've measured the cost, what next? What do we do with them? So we're going to go into a little bit about reallocating resources. Then Mark will give some really good examples from practice of where we've looked at variation and improved value for patients in Wales over the last number of years using some of these principles. And then finally, reference sources before we pause for questions then. Thanks, Mark. So let's start at the beginning then. We all know in NHS Wales at the moment, we have a very difficult financial situation, and we've got finite resources and ever increasing demand from our population. So we really need to understand how our resources across Wales are being utilised to deliver the best care we can for patients. So value, as we know, is all about making the best choices in the use of our available resources. So if we don't know where our resources are going, we can't start to make the right decisions for patients. Next slide, please. So what are our healthcare resources? Our resources are all the things that, you know, we see about us in our daily life when we're in work. It's our staff, our medicines, our equipment and premises. In order to understand the use of our resources, we need to be able to compare using a common currency. So the cost, or the pound sign, is this common currency, and it can help us to understand use of resources at a patient, pathway and a population level. And then once we've done that, the next part is to try to identify variation, and where and how resources can be used differently. Next, please. So let's see what costs we need to measure. So starting at the bottom, we've got patient level costs, and these are key to a lot of the work we do in Wales. They're the building blocks of our understanding of resource usage. Then we can look at services. So, for example, the cost of a knee replacement, which may be about £7,500 in current terms, on average for Wales. We can build those patient level costs into a patient pathway. So we can look at, say, the cost of a cataract pathway, which 1920, a single eye standard pathway on average in Wales was about £1,200. We can build these building blocks of costs into examining the cost of a condition and different adverse effects from a condition. Or we can look at a system level approach and our spend in Wales per head of population. And for interest, that was about £2,800 in 21-22. So if we move to the next slide, please. Building blocks. Now we can use those costs then to tailor an approach according to what we want to measure. So, for example, if we wanted to look at a pathway, there are a number of approaches that we could use. So we could use the patient level costs. We could use time-driven activity-based costing, which may be something that you've heard of, or a blended approach. And I'll go into the detail of those in a few slides further. Or for a system level approach, we could look at program budgeting or condition dashboards. And again, I'll talk about those a little bit on the next slide. So next slide, please. So we're going back to the very start then. So how do we measure costs? This is an example of 3 patient level records. So patient level activity records are collected by health boards and trusts, and they come from our DHCW warehouse, which is our activity warehouse for Wales. And they show all sorts of information. So this writing is very small, I do apologise, but the patient information that's shown there, and you might be able to make it out, are things like the episode start date and time, the length of stay, consultant code, a site of treatment, the specialty of the consultant, and lots of coding information as well, which are diagnosis and procedure codes, which show what treatment the patient has. So each health board in Wales subscribes to an All Wales computerised costing system, which is used to calculate the granular costs for each patient relating to the component parts of their treatment. So on the bottom row there, you can see that there are certain columns with costs against them, and these will be the component parts of a patient's treatment. So we'll have things like ward costs, medical costs, theatre costs, drugs and diagnostic costs and prosthetics costs, overhead costs, all calculated individually for each patient. Some of the other cost pools that I didn't mention are around the GP practice code of the patient, and the area, the health board that the patient lives in as well. So in these records, these patient level records, give us detailed information about the patient and also detailed information attached about an individual treatment that a patient has had and the cost of that treatment. So if we move on to the next slide, please. So each health board at the end of each year will calculate thousands and thousands of records which relate to the patient level costs. We have detailed records, as we've just seen, in the same format for admitted patient care, outpatients, A&E, and critical care services. And then we have more aggregate information for community and even more aggregate for primary care services. All of these records then are submitted in a summarised form to Welsh Government in the following two summary formats. So the first one we can see there is called the WCR1, which is Welsh Cost and Return 1, which gives us average specialty costs per health board for inpatient, outpatient, day case, and A&E and so on. So you can see there on the left-hand side, we've got the specialty name. The first orange box are costs per finished consultant episode or inpatient attendance by health board. So you can see there's a range across Wales when all of those patient level records are aggregated up. And then we've got an all Wales cost. So we can look to some degree around variation, but there will be reasons reasons underlying the variation. Similarly, there are outpatient costs as well. Again, we can see the specialties and the cost per outpatient attendance from the WCR1. So that's an annual return that is provided by health boards to Welsh Government. And the summary All Wales information will be available in the vault for the last 4 years very shortly. The second table at the bottom is the second WCR return. So it's the average specialty cost return, the average HRG return that health boards will submit to Welsh Government. So it contains more granular detail, more drill down detail about the admitted patient care records. So admitted patient care records are clinically coded based on the diagnosis and procedures that the patient has had. And then they're grouped into what are called healthcare resource group codes, which all consume a similar amount of resources. So what we can see here in the blue box at the bottom are the costs of the different kinds of EB06A HRG code, which are cardiac valve disorders with different levels of complication and comorbidity. So we can see that the costs increase as the comorbidity increases. So these are summary returns that group our patient level records into a more understandable and manageable view. Next slide, please. The final return that is submitted to Welsh Government by each of the health boards is the programme budgeting return. And this is a resident, cost per resident, as opposed to cost per provider. So it would group together the costs of all the residents of a particular health board, regardless of who the treating health board was. So it uses broad disease-based categorizations and analyzes the population base. So we can see here a bit of a breakdown of the 2021 All Wales programme budgeting return, which shows mental health, and mental health has been for the last number of years the clinical programme with the biggest expenditure. And we can see that 11.2% of health expenditure was on mental health problems in Wales in 2021. And then we can see the breakdown into different mental health categories. The representation on the right then shows some of the percentages for other healthcare programmes and their relative percentages to each other. Next slide, please. So we've gone through the returns and the information that is submitted to Welsh Government. And I've talked a bit about patient level costing. I'm going to look at the different approaches to costing now when we want to cost up a pathway, for example. So patient level costing is carried out in Wales. It is used to compile the annual Welsh costing submissions, as mentioned. So how do we do it? So in terms of the process, all of the ledger costs, so nursing, medical, drugs, catering, estates, energy, overheads, and so on, are categorised, and then they are fed into a computerized system that works to specific rules and guidelines which are common between Wales and England, and then allocates the costs out to patient level by what's called cost pools. So you'll be able to see, your theatres cost pool, your medical staff cost pool, and your ward cost pool, and so on. So the one thing to note is that patient level costing are the costs reconciled to the published accounts, and they are what's called fully absorbed costs because they reflect the full costs of providing healthcare to NHS Wales. Next slide, please. Another approach that can be taken is time-driven activity-based costing. So this is a bottom-up approach to costing healthcare. So it involves conversations with staff involved to understand the individual pathway steps, for example, and resources consumed for each step. So it looks at who does what, when, and for how long. And there's a bit of an illustration below. So, the conversation for compiling costs for an outpatient clinic may be this amount of time is spent in booking the patient by this member of staff. We've got check-in, we've got observation, we've got consultation, and then we've got consumables and the administration time that will be incurred in that outpatient appointment. So it's, as I said, a bottom-up approach, and we don't have any, well, the way that we've done it in Wales so far, that we haven't had overheads included in this generally when we do time-driven activity-based costing. Next slide, please. So when we are faced with a pathway that we want to try and understand, what approach do we take? So we've got the PLIX information, which is sometimes called the reference cost information. We've got a time-driven activity based costing approach, or we could use a hybrid approach. So what we need to do is consider, when we've got the PLIX or patient level costing, where they exist, those are quite often a good place to start, as time-driven activity-based costing can take a long time. It's quite a detailed process where we map the non-clinical processes and the clinical processes, and it involves quite a lot of detailed investigation. So in Wales, as I said, TDABC has looked at direct costs only, PLIX costs are fully absorbed, so contain both the direct and the overhead cost pools. So generally, when we're considering the approach, we're looking at the time that it will take to carry out a time-driven activity-based costing exercise compared to the reference cost, which may be available, but may not be quite so precise as time-driven activity-based output. So just to give a bit of an example, a number of years ago, we looked at the cataract pathway in Wales. So we used a hybrid approach for that. So the cost per the day case treatment of the patient the reference costs were used to represent that. And then we undertook a time-driven activity-based costing approach to look at the new pre-op outpatient attendances or the one-stop clinic and the resources consumed then. So I think I'll stop there because I've gone through an awful lot of theory. So talked about how we measure costs and how we can map them by patient or pathway to understand the resource consumption. So once we understand the resource consumption by patient or by pathway, what do we do with that information? And I think this is the most important part of the discussion today. So Mark's going to go on to describe how this information can help us to make the best choices to redistribute resources to improve outcomes for patients, and then give us some very good examples of individual projects that have taken place across NHS Wales. So thanks very much, Mark. I'll hand over to you now.
Thank you, Lisa. And next slide, please. So as Lisa's described in terms of the costing, so we've built it up, we've mapped our pathway, we've applied cost to it. What do we do next? And as described, costing isn't an end in itself. It should be set alongside those sort of clinical and managerial decisions of that context of what is happening locally and what they would like to then do with the information. So we're suggesting here that having analysed, there are 3 ways you can consider resource usage along a pathway. And the first step is probably the simplest, is cost avoidance. And this does happen with low value care, where clinical outcomes aren't evidenced. You may then seek to just stop or duplication may be identified in the pathway. So some steps can be taken out by contrasting pathways, or indeed in just mapping them out, so everyone can see very clearly all the stages, and including the stages they're not necessarily involved in on a day-to-day basis. So that's the first one. If we can move on, please. So the second approach is technical efficiency. This is around achieving more with the same or less overall resources. So 2 quick examples here. So the first one is taking the prudent healthcare principle of only do what only you can do, otherwise described as operating at one's license. So the example there is for hours available. So if we spend £100 in the NHS, including employers' costs, we can roughly achieve around an hour of a consultant's time, or 3.6 hours as a physiotherapist, and so on, as we work through the bandings in NHS Wales. So as long as the consultant, for example, could be released to do other productive duties, see more patients, then it may be more cost effective for a physiotherapist or an assistant to then take over and take on some of the workload that they can perform on behalf of the pathway. The second approach is when you've contrasted 2 pathways, you may modify one to look at the more effective. So in the example pathway A and B, if they're achieving the same outcomes, but pathway A has an additional step, do we modify pathway A to look like pathway B? Next slide, please. And the third option is allocative efficiency. And this is where you can use the same resources, but reallocate them within the same pathway then to achieve different ends, so more effective use of those resources. And 3 ways suggested here. So the first is you could move a step earlier in the pathway. So, taking that same resource, but moving it to be more effective. So perhaps pre-education for patients, rather than dealing with them at the event, perhaps you move some resources early in the process. You could move an individual resource from a step to strengthen another process. Where is that resource most effective? So is it that would typically be a member of staff, say some therapies input, would that be more effective at a different point in the pathway? Or you can move some of those resources to create a new step. And we have done this in some of the orthopedic work in the past, where we did that sort of pre-education package. So taking resources from later in the pathway at the same overall cost, but better informing patients, and patients then able to make different decisions at an earlier stage in a pathway. So those are the 3 examples. So next slide, please. We'll now move on to share some of the practical examples that have taken place within NHS Wales, one of which Lisa was talking about just now. So this is to stress that it's not just about the cost in their own right, but it's putting it together with outputs and outcomes. It doesn't necessarily, for those who joined in yesterday, doesn't necessarily have to be formal PROM outcome data. It can be clinically evidenced data, but in some way trying to demonstrate what we achieve as a result of that expenditure and connecting those with the costs of that achievement. So at a national level, just showing, Lisa mentioned the cataract surgery pathway we looked at across Wales. So all the health boards took part, and similarly for a knee replacement exercise. And on the right hand side then suggesting what that gave examples of, as some of the descriptions just used. So cataract surgery gave examples of technical efficiency in contrasting between pathways. We had 17 different cataract pathways in Wales at the time. Those did reduce by the time we revisited, and the cost difference in direct costs, so those clinical and administrative costs, between the most expensive and least expensive pathway were 40%, 40. So that's quite a difference, and people were able to look at that in some detail and benchmark why those differences were occurring, where things weren't being utilised in perhaps the most effective way. Carrying on with that example, then at an Iron Bevan health board where I was at the time, we were able to combine it with formal PROM outcome data from a study, and then experiment with presenting value then to look at the outcomes alongside the costs and the pathway. Elsewhere, there's also been some regional work, example there for prostate cancer, and what that gave an example of is being able to use existing costing data, but in this case, time-driven activity-based costing, to map out and cost an entire and very complex cancer pathway for all the alternatives available. So there can't be many pathways that are more complicated than that, and we did manage to do that and deliver it to the Welsh Urology group to consider, and some improvements were made as a result of that. At the other end, and the final one on the slide, pulmonary rehab, I've noted their speed, and what I mean by that is, although there were 5 different teams, each team took a couple of hours to map out quite a straightforward for them process, but then contrast them between the 5 different counties in that area, and look at that variation and understand, well, what were the differences in outcomes compared to the inputs received and the different services being provided. Next slide, please. Then to bring it up to date, Lisa and I co-chair a national group in Wales looking at intelligence, costing and value, and colleagues share in that group some of the work underway across Wales. So these are all examples by organisations in Wales from the past year, where costing is involved as part of that process, but as you can see, many of them are also considering value, allocative efficiency, technical efficiency, etc. So it's just to highlight the range of work, and this is really just the tip of the iceberg on what's going on in Wales at this point in time. Next slide, please. So having considered some of the examples, now the final part of this is around sources of how we share this information and how we share some of the education. So for those in Wales, this tool is available, and signpost you to it through the link, and we will make a copy of the slides available. So the Vault, as it's known, so the Value Allocation, Utilisation and Learning Toolkit, was established in 2021 at a national level. It's an excellent tool that enables us to log and share some of the intelligence work, to share the learning and provide some help in how we all make better use of resources. So as noted, anyone in NHS Wales can access this. And there are several sources of useful data, as you can see on the right-hand side, in subcategories in population health, efficiency, etc. The one particularly to note today is obviously value-based healthcare, and I will go on in the next slide to describe some of the educational products we've now produced and made available through that, but also to note that there are some national toolkits available in the tool as well. So diabetes as an interactive dashboard, for example, is one of those toolkits. Next slide, please. From an education perspective, principally for the finance community, but made available to all who are interested, we've considered the education need at 3 levels of inquiry or competency, if you like, beginning with a broad introductory level. What if someone just wants to dip their toe in the water, have a basic overview of costing? Hopefully you've picked up some things today, but there's a simpler and shorter version available as well. But also that is part of a larger package on value-based healthcare itself. So as a finance community, we collaborated with Swansea University, who were putting together this online package with a web address noted on the right-hand side, and that gives a brief introduction as an online module-based course to all facets of value-based healthcare, and I would recommend that if people are interested. And also noting that Swansea Bay colleagues kindly made available some of their implementation work, and that's another useful resource on the site for people trying to understand, well, how do you do this? How do you put it together in that wider value context? So it's an introductory level. Hopefully they're useful resources. Next, please. Where we'll go on then to the next level, which is practitioner level, where we as a finance community then put together some resources, housed as noted on the Vault. So we began with a broadly around a 1 hour toolkit where Lisa, I and a colleague Craig presented an overview of finance in the context of value-based healthcare, similar to today, just a little bit more. But then for each of the core elements, we were getting feedback on some people wanting a little bit of more detail in specific areas as they were trying to implement this locally. So that was broken out by Craig principally with support into 6 key modules that are online, can be viewed, and as noted there, so beginning with value-based healthcare through a finance lens, but broadly what is value-based healthcare, and then moving on through the other aspects to build up the full picture of how, when and where to use this data. The final piece in the jigsaw we're currently wrestling with, and it will be that expert level of education, but recognising that's probably for a handful of individuals within NHS Wales, but has a UK and international context, and will probably become more important as we spread and scale this work now in the years ahead. And next slide, please. Here we go. Thank you very much. Thank you for your attention. Apologies very much for the hitch at the start with the presenting. That's all my fault. I don't know what the technical hitch was quite, but we will make the slides available to colleagues if they wish to view them, and hopefully you were able to follow the discussion at least until we caught up. So apologies for that.
No worries, Mark. Thank you very much, and thank you to Lisa as well. And yeah, I know that's not easy when you know that there's technical stuff going on behind the scenes, Lisa. So thank you for keeping going. That was great. So if you've got any questions for Mark and Lisa, please feel free to pop them into the question and answer section there. And I know that we've had a few coming through while you were talking. So I'll put them to both of you if that's okay, or pass them on to whichever one of you thinks more suitable to answer. So if we go to Hayley Bennett first of all, good afternoon, Hayley. Hayley says, are the average costs by HRG code for Wales publicly available, please? These costs seem similar to NHS reference costs from NHS England, but having the Welsh costs would be really helpful. Lisa, you're nodding, so you've put yourself forward for that one.
Yeah, great question. Thanks, Hayley. Yes. So the Welsh HRG codes are calculated using the same principles as the NHS England reference costs. We've been very careful to keep those principles similar so they are comparable. And the answer to your question is yes. We will, within the next few days, be posting the WCR2, which are the Welsh reference costs, if you like, onto the vault. So anyone who has an NHS Wales email address can apply for access and will be able to see those HRG coded costs and also the average specialty costs for Wales for the last few years. And we've also posted the NHS England reference costs there as well, just for comparative purposes. So yes, is the answer to your question.
Thanks, Lisa. Next question from Sarah Lawrence. Afternoon, Sarah. I suppose it's to both of you, I suppose, really. Is our coding really good enough to enable accurate costing as we look to increase, where appropriate, procedures in an outpatient or clinic setting? Is it clear our outcoming and coding of what has actually happened to the patient is effectively lost?
So that's another really great question, because we all know that coding in NHS Wales is a big problem in some areas at the moment. So the great beauty of our patient level cost system is that we have a patient record and we cost it regardless of whether it's got a code against it or no code against it. So, for example, if something is uncoded, we call them U codes. They've got UZ as their HRG code instead of a legitimate HRG code. We would still know that that patient was treated by a certain consultant in a certain specialty, and we would have calculated individual costs for that patient based on the resources that they consumed. So if you were looking at a patient level, even though the record is encoded, we would still have the right costs for that patient. Similarly, if you're looking at our WCR1, which is the average specialty cost return, those costs would still be aggregated to the correct specialty and point of delivery. So we would have an accurate specialty picture. The area where it does fall down a little bit is when we get to HRG level. So if we haven't got a code against that patient, an HRG code against that patient that is legitimate, it would go into the U code bucket. So it may affect, well, it would affect the average costs for certain HRGs. So that's why it's so important that we try and do all we can to address any problems that we have with coding, because it will have an impact on those average HRG costs.
Thanks, Lisa. Mark, anything extra to add from that?
No, I think it is just that general point that it's the use of data, isn't it? So if data isn't used, if it's not being widely used, then improvement isn't driven. And people think, well, why are we bothering? You know, coders spend a huge amount of time trying to deliver this. But I think as value expands, as Lisa says, this most detailed level of HRG will become increasingly important, because it's how we identify very specific elements to pathways. So rather than just orthopedics as a specialty, we can see that it wasn't only a hip, but it was a hip for a complicated patient, or it was a replacement or a washout or whatever else. You know, it's that granular level that is really so important then. And as Lisa highlighted through the slides, you know, it also gives us the age, etc., of the patient, so the more rich detail around it as well. So it is crucial to trying to do this work, but not, we can find ways to work without it, but it's much easier if it's there to begin with.
Yeah, great, thank you. And a question from David Whaling: is there any advice? Is there any advice or guidance on how to perform a simplified version of these processes for lower level cost effectiveness evaluations? Yeah, I think you've answered that too. Yeah. Go on.
Hopefully, but just to clarify, I think yes. So there are various levels of cost information, as Lisa highlighted. So picking up some of these off-the-shelf ones, if you can, reference costs, if that applies, you can apply it straight away then, or something close enough. And it depends on the degree of accuracy. So if David would like to publish something, he probably needs something a little more robust. If, as I think is being suggested, if it's looking at very broad cost effectiveness, is A better than B? Then a broad costing may do the job to begin with, at least, and see if it's worth exploring. But certainly get in touch with your finance colleagues if that's helpful as well, who will be able to point you towards or assist with more detailed calculations if required.
Great, thanks, Mark. And Sonia asks, and Sonia, there's no need to apologise at all because I'm big on these sort of things as well. What is an HRG?
Sorry, we talk in acronyms in
We're
our cost
terrible
world. We've
for
got
it,
our
aren't
little
we?
community and we just speak to each other with these abbreviations. So sorry about that, Sonia. It stands for Healthcare Resource Group. So it's a grouping that is arrived at through a clinical coding mechanism. So there's so when a record is coded, but well, first of all, the record is written up by the consultant. Then our medical coders have the wonderful job of trying to decipher that and to fit it into a specified number of codes. So each record will have a number of diagnosis and procedure codes against them, and then those diagnosis and procedure codes are fed into what's called a coding grouper, which is used across Wales and across England, which sort of magically sorts them all into different categories. So in simple terms, it may be a simple hip replacement, a hip replacement with complications of level 1, a hip replacement of complications level 2. And each of those categories are called a healthcare resource group, and will have a letter and a few numbers attached to them. And so it allows us then to categorise patient activity into similar resource categories. I hope that answers your question. It was a bit of a long-winded way of answering, but I hope that that makes sense.
It wasn't long-winded at all. There's no need to apologise, Lisa. We all do it. We all have those languages, and it's good when people pick us up on it. I always think, always happy to explain. Another question coming in then, and please, if you've got any questions for Mark and Lisa, pop them in the Q&A. Ain says, will costings be accessible to the medtech sector? I can access NHSE and NHS Scotland costings for creation of HER tools, but not the Welsh costs.
So at the moment, this information is only available to people with an NHS Wales email address. But by all means, if there are individual requests needed to be made, then, please contact us and we can discuss it.
Okay, but yeah, that data's just available to the NHS Wales address. Okay, well, that's all the questions that we have at the moment, as far as I can see. So just leaves me. Sonia says that did answer my question. Thank you very much. Thank you, Sonia. So yeah, that just leaves me to say thank you to both of you. We really appreciate it. A fantastic presentation, and yeah, it was great to hear it. And Mark, we will put all those links to the vault, etc., on our website as well, to make sure that that's all linked through with the recording of this session, so that people can access any of those resources that they want. So genuinely, thank you to you both. Really appreciate it. That's it for today for Value in Health Week. Tomorrow we've got 2 sessions, one in the morning 10:30 to 11:30, and one in the afternoon again 2 till 3. Both are called Value Voices, where we're looking at making an impact. So we're going to hear from 6 value-based healthcare projects from all over Wales, and to hear their story. So thank you ever so much for joining us, and we'll see you tomorrow. Thank you all. Bye.
Thank you. Bye.
Thanks all. Bye.